Saya melihat ada Pak Handoko dan Pak Doni ya. Selamat.
Ya, selamat sore, menjelang sore ini, Dok. Maleta, Doni, Pak Stanggang, Pak Ergo, yang muncul saya sendiri, Handoko, Dok.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. My name is Dr. Jaka, and I have the honor of being your host for today's event. Welcome to the international lectures titled Meet the Experts, all about orthosis and assistive device for cerebral palsy. First and foremost, I let us express our gratitude to God Almighty. It is by His blessing and mercy that we are able to gather here in the good heart and with the opportunity to learn and grow together. It is our hope that today's lecture and discussion run smoothly, offering us fresh perspective and valuable insight that will enrich our understanding. May the knowledge shared here today enable us to provide the best care for our patients. Before we dive into the main sessions, it is my great pleasure to invite the head of the Physical Medicine and Rehabilitation Studies Program at Pajajaran University, Dr. Irma Ruslina Devi, Doctor Specialist in Physical Medicine and Rehabilitations, Consultant in Geriatric PhD, to deliver the opening remarks. Without further delay, the time and screen are yours, Dr. Irma.
Assalamualaikum warahmatullahi wabarakatuh. A very good day to all participants joining us today. On behalf of Physical Medicine Rehabilitation Education Program, I welcome all of you to this guest lecture with the title Meet the Expert and All About Orthosis and Assistive Device for Cerebral Palsy. First of all, I would like to express my deepest gratitude to our distinguished speakers, Professor Jules Becher and also Miss Lydia, and also all participants who come today together to discuss in this guest lecture and guest presentation. Your presence is truly enrich this forum, and I hope today's event will serve as a valuable opportunity for all of us to exchange knowledge, idea, and also perspective. As the head of physical medicine and rehabilitation, I believe this event will advancing the understanding of physical health and rehabilitation through multidisciplinary approach, especially about orthosis and also assistive device for cerebral palsy. It is our hope that knowledge shared today will inspire further research, spark meaningful discussion, and also encourage collaboration across the borders. Before we begin, I would like to extend my heartfelt appreciation to the organizing committee for the hard work and in preparing this event, and to all of you for your participation. Without further delay, let us proceed to the next session, and I wish you all insightful and enjoying session. Thank you. Wassalamualaikum warahmatullahi.
Thank you, Dr. Irma. Before we dive to the main session, it is fitting for us to start this event with an opening prayer. The prayer will be led by Dr. Yudi. To Dr. Yudi, the time and screen are yours.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Let us take a moment to calm our thoughts, lower our heart, and humbly pray to the Creator. Please allow me to lead this prayer according to Islamic teachings. For those of you with different faiths and beliefs, you are invited to pray according to your own faith and tradition. A'udzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Alhamdulillahi rabbil alamin. Ar-Rahmanir-Rahim. Maliki yaumiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdinas siratal mustaqim. Siratal ladzina an'amta 'alaihim ghairil maghdubi 'alaihim waladdallin. All praise and gratitude are due to you for the blessings, grace, and mercy you have upon us, enabling us to gather here in good health and well-being. On this blessed day, we come together, humbling our hearts and soul before you, asking for your forgiveness and guidance. Today, we gather for the lecture, ease and smoothing this proceeding of this event. We ask you, O Allah, to bless us with success and guidance in every piece of knowledge that we will receive today. Amin. Ya Rabbal Alamin. Assalamualaikum warahmatullahi wabarakatuh. Back to MC.
Thank you, Dr. Yudi, for the prayer. May our event proceed successfully. And now it is an honor for me to announce to all participants about our speakers for today's webinar are Professor Jules, MD, PhD, and Mrs. Lydia Angraini, Engineering Bachelor Degree Specialist Custom-Made Assistive Devices, and also our beloved moderator, Dr. Marietta Santi Prananta, Physiatrist Pediatric Consultant. We are so grateful for having you here with us. And before we invite the speakers, it is my honor to introduce our moderator for today's sessions. Our moderator is Dr. Marietta Santi Prananta, Physiatrist Pediatric Consultant. Before we move to our first agenda, allow me to present the curriculum vitae of Dr. Marietta. Dr. Marietta is Pediatric Rehabilitation Consultant at Hasan Sadikin Academic Hospital and the Faculty of Medicine Pajajaran University. She earned her pediatric degree from the Faculty of Medicine, University of Pajajaran in 2005 and became a consultant in pediatric division under the Indonesian Pediatrics Collegium in 2020. She is an active member of the Indonesian Pediatrics Association. Without further delay, the time and screen are yours, Dr. Marietta.
Thank you, Dr. Jaka. Dear participants, before we begin the lecture, let me read the curriculum vitae of our teacher, Prof. Jules. Prof. Jules is a professor emeritus in pediatric rehabilitation medicine, specialized in cerebral palsy and spasticity-related problem at Amsterdam University Medical Center. Without further delay, let us welcome Professor. Good morning.
Oh yeah.
Good morning, Professor.
Good morning. I'm sorry for the delay, but I had probably an old schedule that started at 9:30 my local time. So I apologize.
Yes, yes. Okay, Professor. Yeah. Okay, Professor. The time is yours.
Okay, thank you. So thank you for the invitation. It's a great honor for me to give a lecture for you all. And if there are questions, you can ask them by the chat, and Dr. Marietta can interrupt me if the questions are about the content of my lecture. It's no problem to interrupt me. Yeah? Okay. I will talk about the pathological gait in cerebral palsy, any correction with orthoses. But at first, I will give a short repetition of the mechanism of normal walking. For when you understand normal walking, then it's easier to understand abnormal walking. And I think you're familiar with the description of gait according Perry, which looks at the gait with a stride consisting of a stance and a swing phase, and it's all divided in 8 subphases: initial contact, loading response, mid-stance, terminal stance, pre-swing, and then the swing phase, initial swing, mid-swing, and terminal swing. So I will use this terminology in this lecture. Well, when we look to gait, we can measure the ground reaction forces in stance phase. And the ground reaction forces can be divided in 3 directions: the vertical component, the forward-backward component for deceleration and acceleration, and the sideward component. As you see, the vertical component can be more than the body weight. And that's because of the deceleration and the acceleration. You see here the deceleration and here the acceleration. So the kinetic energy is added to the static energy of the body weight. So the deceleration is after initial contact, and the acceleration is during push off in terminal stance and pre-swing. There's always a sideward force, and that's because of the center of mass in the body is located in the middle of the belly. So when you're standing on one leg, you have always a sideward force. Okay, when we combine the 2 forces, then we can measure the force factor. That's the direction of the force. And in this example, the force factor is a combination of the vertical force and the forward-backward force. And the force factor tells you about the joint moments. And here you see the representation of the joint moments. And the moment is determined by the distance of the force to the point of rotation in a joint. And you see in this example, this standing straight, you see that the force factor is going through the ankle, almost through the knee, just little behind, and through the hip, just little before. But when you are standing with flexed knees, then you see an increase of the net joint moments because of the increase of the lever arms. So the lever arm is the distance between the point of rotation in a joint and the position of the force factor. And I invite you all to stand up at this moment. Yeah, please stand up. Yeah, okay. And flex your knees. Flex your knees. And you can feel the difference in the joint moments. And it's much heavier in standing with flexed knees than with fully extended knees. So please now you can come to full extension and stay relaxed. Yeah. And you feel relaxed now in standing. And do you have any idea which muscle is controlling standing? Or which muscles? I can look in the chat if somebody can give an answer. So in standing, you can feel on yourself which muscles should be active for relaxed standing. I don't see any message yet. So the question is, which muscles are we using for relaxed standing? Yeah. The quadriceps. Quadriceps. No, it's not the quadriceps. Yes. Yeah. Yeah, there are more possibilities. Actually, the gastroc is acting above the knee and is anatomically flexor of the knee. So that's not exactly correct. And the hamstrings are also flexors of the knee. Yes, yeah. And I see here the best answer is the gastrocsoleus. So it's mainly the soleus who's controlling the standing. Thank you all. You can sit down. But what the mechanism is that the soleus is from the tibia to the calcaneus, and this is controlling the position of the tibia. And by controlling the position of the tibia, it can make the direction of the force factor on a way that's just through the knee and through the hip. And when you have no moment, you don't need compensation by muscle activity. Dus in relaxed standing, we use the soleus for the direction of the factor and to neutralize the moments around the knee and the hip. And then we need some gluteus activity to keep your trunk above your hip. Yeah. But you see the difference with standing in flexion. Then when you have low joint moments, you need low level of muscle activity. Okay. Now we come to the trick of human walking. Here you see the stance phase from initial contact till toe off, and you see the direction of the force factor. And you see from initial contact till mid stance, you see that only in the loading response there is a slide, a knee flexion with an external flexion moment around the knee. And you have a small flexion moment around the hip and almost no moment around the ankle. For you, the force factor acts around the joint like a rope. And when you want to determine the direction of the movement by the force factor, you can pull on the rope and then you see how it works. So when you in loading response pull on the rope, you get flexion in the hip and you get flexion in the knee. Yeah. And you can see in polio patients, they can avoid this flexion very easily by skipping the slide knee flexion in the loading response. And for you, remember, you can walk with a complete paralysis of the quadriceps muscle. You don't extend your knee in stance with the quadriceps. Yeah, you only use the quadriceps as compensation when you're walking in flexion. Yeah. But for normal walking, you can walk with a complete paralysis of your quadriceps. And you can see so in polio patients, but also in patients with a diabetic neuropathy. They could have also a complete paralysis of the quadriceps muscle. I don't know if you have ever seen it in a patient, but I remember it very well that the polio patient entered my consultancy room, just normal walking. And when I started physical examination, he had a complete paralysis of the quadriceps. And I thought, by hell, how did he manage it that he could walk? So then I let him walk again, and I observed that he only skipped the slide knee flexion in the loading response. Okay, when we look to mid stance, you see that the factor is through the ankle, through the knee, and through the hip. And we control the position of the factor by an eccentric contraction of the soleus muscle. You see here in initial contact, the tibia is backwards, and in mid stance, oh, I'm sorry, the tibia is vertical. Yeah. So the forward movement of the tibia is controlled by an eccentric contraction of the soleus muscle. So when you have soleus hyperactivity, you get hyperextension in mid-stance, and when you have soleus weakness, you get hyperflexion in mid-stance. I hope that's clear. Well, the second part is from mid-stance to toe off. And what you see in terminal stance, there is acceleration, and that causes a forward bending of the factor. And because of the forward bending of the factor drops before the knee and behind the hip. So we have an external extension moment around the knee and around the hip. So by the acceleration and the forward bending of the factor, we stabilize the knee and the hip. So we have full knee extension without any activity of the quadriceps and without any activity of the gluteal muscles in terminal stance. Only by the gastroc and soleus, by the acceleration. I hope that it's clear. And this is what we call the plantar flexion knee extension coupling. Because of the activity of soleus and gastroc, we stabilize the knee and the hip. And that's very special, for you know that the gastroc is anatomically a flexor of the knee. Yeah. But the trick is in kinematics during movement, the muscle function is often totally different from the anatomy. Actually, the anatomy doesn't learn you much how the body and the muscles work during activities. Well, in pre-swing, you get the unloading of the stance leg. And that's happening here. And at this moment, when you unload, the gastroc starts to work as a knee flexor. Yeah, for the influence of the factor reduces, and the rapid knee flexion in initial swing is because of the push-off activity of the gastroc. So in initial swing and pre-swing, the gastroc starts to work as a knee flexor, and your foot clearance is caused by the push-off activity of the gastroc and soleus, and not with your tibial anterior muscle. For we all have, in pre-swing and initial swing, a plantar flexion in the ankle. And the orthopedics like to say equinus, but equinus means only plantar flexion in the ankle. When you look to the whole gait cycle, we have plantar flexion in the ankle after initial contact, in the loading response, and in terminal stance, we get dorsiflexion in the ankle. And then in the end of terminal stance and pre-swing, we have plantar flexion in the ankle, and in initial swing, we have also plantar flexion in the ankle. So actually, the most gait cycles we have plantar flexion. So the message the child walks in equinus is actually nonsense when you don't specify in which phase of the gait cycle. Yeah. And only in mid-stance plantar flexion in the ankle is abnormal. Yeah. Okay. So I repeat, the gait cycle from initial contact till mid-stance is controlled by an eccentric contraction of the soleus muscle. The soleus muscle is from the proximal part of the tibia to the calcaneus, and the phase from mid-stance to toe off is controlled by soleus and gastroc muscles, by the acceleration during push off for the factors. Okay, keep this in mind. Well, to prove that it's my story, you can see here normal walking, and you see the factor in mid stance. In terminal stance, it drops before the knee and behind the hip with nice hip extension. And in toe off, you get knee flexion, plantar flexion in ankle with foot clearance. When we look to the lower window, you see the blue line is the soleus muscle, and the yellow line is the gastroc muscle. And you see in stance phase, at first, in initial contact activity of the blue line, and in terminal stance, you see the combination of the blue line and the yellow line for the push-off, and that reflects soleus and gastroc activity. Okay, I hope it's clear. Are there questions about this in the chat box? I don't see questions. Is it all clear for everybody? I think so. Then I proceed. Well, based on clinical observation, I described 5 main types of gait patterns, and these gait patterns offers a framework for clinical decision
They still
making.
try to understand what you are just deliver, Professor.
Okay, is there a question? Feel free to ask questions, for it's very important that you understand this mechanism. Oh, I may proceed. Okay, thank. Okay, well, this is the summary of the gait types, the Amsterdam gait classification. Well, the first type 1 is only a problem in swing, and it's insufficient foot lift in mid-swing. Yeah, that's also described as drop foot, but actually it's plantar flexion of the ankle in mid-swing, and that's due to insufficient force of the tibial anterior muscles, so the ankle dorsiflexors. Type 2 and 3 are a problem of hyperextension of the knee in mid-stance, In type 2 is hyperextension of the knee with full foot contact. And type 3 is hyperextension of the knee with heel rise. When you have heel rise in mid-stance, that means that the muscle activity is so strong that you lift your whole body, your whole body weight. So that's more serious. And then we change to type 4 with hip flexion and knee flexion with heel rise. Yeah? And that can be together with plantar flexion of the ankle, but that's not necessary, for you can have a neutral position in your ankle with knee flexion. Yeah? And type 5 is defined as flexion in hip and knee with full foot contact, and you see here an increased dorsiflexion. Yeah? So in summary, type 1 is a problem in swing, type 2 and 3 is a problem van hyperextension in mid-stance, and type 4 and 5 is a problem with hyperflexion in mid-stance. Yeah? That's not too bad to remember. Yeah. Okay. Well, I show you the gait types, and this is type 1. And you see the girl has a unilateral spastic paresis on the right side, left side, sorry. And in swing, you see an increase of the plantar flexion with a forefoot landing. But she has a good level of walking. She should have GMFCS 2 level. Okay. Well, this, as it's a problem only in swing, it means that there are low forces. For swing is an open loop motion with little forces. So a kind of basketball shoe is already sufficient to support the foot lift. And now you see she has a kind of mid-foot landing with the shoe. So this type does not need an AFO. Only when you have a severe foot deformity in stance, then you can give a supramalleolar AFO for that supports the foot lift and correct the foot deformity. The supramalleolar ankle foot orthoses are not very common in Indonesia, I think. I haven't seen them, but it's a circular AFO, and it ends just above the malleolus, medialis, and lateralis. Okay, this is gait type 1. Now we proceed to gait type 2. And you see there is insufficient foot lift in swing, so that can be in any gait type, as a mid-foot landing. In loading response, there's some knee flexion, but then in mid-stance, you see the vector drops forward in the foot. Here we go, and we get a hyperextension of the knee with a hyperextension moment. And the moments around the knee are quite high. So even it doesn't look so bad. The moments around the knee are high, and in young children, it can be harmful. So that's why it should be corrected. And when you look to the ground reaction force, you see an increased deceleration because of the premature activity of the soleus muscle but you see a good push off. So the voluntary force of the soleus and gastroc is still good in this type of walking. So this mechanism is due to hyperactivity of the soleus in the loading response. And when you look to the ankle movement, you see that after initial contact, there's a stretch on the soleus and gastroc muscle. So this is due to hyperactivity of the stretch reflex of the soleus muscle. It's abnormal activity. The soleus muscle is from the proximal part of the tibia to the calcaneus, and it pulls the tibia backwards. You can show once more, and then you can see what's happening. So you get a forefoot landing. No full knee extension. There's a backwards position of the tibia. Then it moves forward, the tibia, and now the tibia is pulled backwards. You see? And the factor drops in the top of the foot, and you get a hyperextension of the knee. So it's hyperactivity of the soleus muscle. Yeah. Well, you can easily correct this with an AFO, a dorsal AFO. For you have to correct plantar flexion, and you see heel contact, knee flexion in the loading response. In mid stance, the factor drops through the knee and through the hip, and in terminal stance, it drops before the knee and behind the hip. For that's very important that you keep on having full knee extension in terminal stance and full hip extension. Otherwise, you get flexion contractures. And when you look to the force factor, you see the vertical force is corrected nicely. Well, on the right side, you see the walking at normal speed, and you see you can observe that's a very nice way of walking. And this AFO can have an ankle joint, so a plantar flexion stop and dorsal flexion free, for that walks better than when you, oh, I'm sorry, than when you have a rigid AFO. And as this gait type allows some dorsal flexion, as the forces are not that high that he lifts the body weight, you can check for the passive range of motion of the ankle, and when there is an option to dorsiflexion, you can give an ankle joint, and the most simple ankle joint is a tamarack joint, and that's available in Indonesia. Okay, so this is gait type 2, knee hyperextension in mid-stance with without heel rise. Well, this was a child I assessed in Sri Lanka, and you see he is at the age of 5 years, and you see what's happening when you don't correct it. Then you get hyperextension mobility in the knee, and when you have it, then it's much more difficult to correct with the AFO. Yeah. So it's not harmless when you don't correct this gait type, although in the beginning it doesn't look so bad. Well, now we proceed with gait type 3. you see slow motion, forefoot landing, and hyperextension of the knee with heel rise, and extension of the knee in terminal stance. When you look to the vertical force in this child, you see that the raise of vertical force in terminal stance has been disappeared. Yeah. So the soleus and gastroc are active in loading response and mid stance, but there is no active push off. Actually, the voluntary force of the soleus and gastroc is low, but there is a strong reflex activity in loading response and mid stance due to stretch. You see, the factor drops to the toes, and you get the hyperextension of the knee in mid stance. In slow motion again, you have a forefoot landing, full foot contact, the factor drops to the toes, and you get a hyperextension moment around the knee with heel rise. And you have no active push off. Yeah. So this is type 3. But you see, it can walk quite fast in a normal walking. Yeah. And as you see now, the difference in the time you have for observation, you need to make a video with your cell phone if you really want to observe and analyze the gait pattern. And you must take a good sagittal plane and a good frontal plane, not something in between, for you then you can't observe the real gait pattern. Yeah? So take your time to make a movie of the sagittal plane and the frontal plane when you like to observe the gait type of your patient. Okay. Well, you can correct it with a dorsal AVO without joint. For the forces are so high that there is no option for dorsiflexion. And you can tune the factor with the heel under the AVO. So the AVO must be made always in 0 degrees angle, no plantar flexion. And you can tune the factor with some heel under the shoe or under the AVO. It's also possible when you use sandals. You see the heel is fixed with tape for the tuning of the AVO. For when you give more heel, then the extension of the knee comes later in the gait cycle. When you look again, and this is rapid here, you have heel strike because of the AVO. Then you get full foot contact, you get some increased knee flexion in loading response, but now the factor goes through the knee in mid stance and before the knee in terminal stance and behind the hip. It's very important that you keep on having full knee extension, for otherwise you promote hamstring shortening and knee flexion contracture. Okay, so this is a rigid AVO, a dorsal AVO. And when you look to the ground reaction force, that you see now, there is a push-off in terminal stance. And how is it possible for you fix the ankle? So you have no ankle movement. And the vertical force in terminal stance is improved. How is that possible? I like to get suggestions from you in the chat. How is it possible that in barefoot walking you have no push-off, and with a dorsal AVO without joint, you get an improvement of the push-off power? That's a very difficult question. For you see in the ground reaction force, here is the second peak, and actually this looks like a normal ground reaction force. How is it possible? For we block the ankle movement. And the physiotherapists always state that when you give an AVO, then you induce weakness of the gastroc because of blocking of the movement. That's nonsense, but they say it always. And you see now we get a normalization of the vertical force. I don't see any suggestion from you. I'm still waiting. Nobody has the clue how this is possible. I'm not a magician. You see that's happening. I have a trial. Very brave. Thank you very much. Maybe by increasing the flexion moment in the knee will create a push of the ankle when extending in mid-stance. Well, the increase of the flexion moment is in loading response. So I don't think that it can cause a push off in terminal stance. But it's a good trial. You think about it. Are there other trials? No other trials. Well, I come to it later to the mechanism, but the foot plate of an AVO has also a kind of stiffness. And that stiffness of the foot plate that is loading in terminal stance and gives some push-off power in pre-swing. So it's because of the stiffness of the foot plate of the rigid AVO. I will show you later the mechanism. Okay. Now we come to a more difficult problem, and that's the type 4, knee flexion in mid-stance with heel rise. Here you see slow motion, you see increased dorsiflexion in loading response with knee flexion and hip flexion, and she get at the end of loading response starts heel rise, and she keeps on having knee flexion in terminal stance. And actually, that is a very bad sign for she don't extend the knee fully in the whole gait cycle. And these children develop hip flexion contracture and knee flexion contracture during growth and end up in the wheelchair without therapy. For you felt by yourself in standing how heavy it is in standing with knee flexion. And when they have to walk only with knee flexion, that's when they have increase of body weight, then walking becomes more and more heavy, and then they reduce the walking by day, and then they get weaker, and then they end up at the age of around 20 in a wheelchair. Yeah, and you can prevent this with orthotic treatment. But you have to start in time, immediately when you see the child when he's walking by himself, with or without walking aid, and he's walking all the time in flexion, then you have to start the correction before shortening of muscles and contractures develop. Okay. Has any of you a suggestion? What's the etiology of this gait type? Okay. Yeah, that actually, oh, I see still a suggestion of William about the last question. Maybe because it stops further plantar flexion, Prof. Yes, actually, that's true because of the stiffness of the foot plate. Yeah, that's a good suggestion. Thank you. Well, this gait type, type 4, well, it's written already. It can be due to hyperactivity of shortening of the gastroc, not of the soleus. So it's weakness of the soleus muscle anyway, for the soleus muscle does not control the forward movement of the tibia. You see, in midstand, there's an increased dorsiflexion. With heel rise, for there is no range of motion. You see the valgus deformity in the foot that hides actually the plantar flexion position of the calcaneus. So there's weakness of the soleus anyway in this gait type, but hyperactivity of shortness of the gastroc. The gastroc is attached above knee. So because of tightness, it can block the extension movement in mid-stance and terminal stance as the rope is too short. I'm sorry, I take some water. But the gastroc could also be hyperactive for activity of a muscle. Actually, biomechanically makes a muscle stiff. Yeah. So in normal walking, you have in stance from loading response, a gradually extension of the knee. And when you have a stiff gastroc, then it blocks the extension movement of the knee, and you see the vector drops to the toes. And when you look to the vertical forces, you see that there is no push off. So actually there is, or a slight push off. Actually, it's weakness of the gastroc. So probably in this child, it's a combination of weakness and shortening. Yeah. So gait type 4 is anyway weakness of the soleus because of the forward inclination of the tibia in from initial contact to mid stance. Here, look, you have increased forward inclination of the tibia. So that causes knee flexion, increased knee flexion in loading response, but you don't get full knee extension in terminal stance, and that can be due to shortening of the gastroc and also weakness of the gastroc. Yeah? I hope that's clear. I see no questions. Well, how to solve this problem? Well, when you have excessive flexion, then you have to make a ventral AVO for, you have to push back the tibia. And you have the increased inclination of the tibia. So you must push back the tibia. And the forces are high for it during walking. So you, with a ventral AVO and a rigid foot plate, you can push back the increased inclination of the tibia in loading response. With a dorsal AVO, you block plantar flexion, and a ventral AVO, you block dorsiflexion. Yeah? And is any of you familiar with the design of a ventral AVO? Now you can answer yes or no, and I like to see a lot of yes or no's. So have you ever seen a ventral AVO? I see a lot of no's and a yes. Yeah, very good. Not too much. I think I have 60 participants, so there are some blind students or they haven't seen anything. Okay, so one yes, Lydia. Okay, and no, a lot of no's. Yeah. Well, it's possible to make it from polypropylene with a specific technique. And in the rehab center Harpanyaya, they can make a ventral AVO of polypropylene. So they can ask, and probably you can find also some instructions on internet. But I think you, as a prescribing doctor, you can ask for it for your technician, for your orthotist. Okay, thank you for the answers. Well, another mechanism to correct knee flexion in terminal stance, that's only in terminal stance, is by blocking the foot rocker in terminal stance with a rigid insole. I will show you the effect. Well, here's the child walking with the ventral AVO. Well, you see always is the support of foot lift in spring, so you have a heel contact, and in terminal stance, you see extension moment around the knee, and in terminal stance, extension moment around the knee and the hip with increase of knee extension. And you see there's no full knee extension when this child there is already some knee flexion contracture, but with the help of the AVO, she stretched the knee every step. So you can expect on the long term that the knee extension will improve with the help of the AVO. So you see the AVO push the tibia backwards, the vector drops to toe, for you have a rigid foot plate, and on that way you increase the knee extension moment around the knee and the hip. Yeah. And you see, when you look to the ground reaction force, by the rigid AFO, there is no push-off moment anymore. For that's impossible. The foot plate is totally stiff. This AFO is made of carbon, and that has the advantage that it's very low weight and very strong, but it's also very expensive. So you don't have the possibility. When you make it from polypropylene, they need some reinforcement of the bars, which is strip, it can be a metal strip within the polypropylene, and the side bars of the foot plate should be longer than normal to block the flexion of the foot plate under the body weight. That must be very rigid, for otherwise mechanism will not work properly. Yeah. Well, you have to start at young age with a ventral AVO. When a child is 6 years, and then you start with the use of a ventral AVO, it takes about 6 months exercise before they are able to walk smoothly with the AVO. It's a big change. Yeah. I don't know if any of you have done some skiing, but it's like walking with ski shoes, very rigid shoes. Yeah. But you can correct with ventral AVO knee flexion in mid stance and terminal stance. Actually, in terminal stance is the most important, for that related to the development of flexion contractures. Okay, this gait type 4. Well, in milder cases, like this child, when you look in detail, she's GMFCS 2, but when you look in detail, she has some increased flexion in loading response, and in terminal stance, she does not have full knee extension. Yeah. And when she's walking fast, you hardly see it. But even then, it's a risk for future. And she has quite a good push off, but despite that, she has no full knee extension. And yeah, it can be due to tightness of the gastroc, blocking the full knee extension in terminal stance. Well, the solution is to give a rigid foot plate, and this is the carbon foot plate, but you can also make it from wood or from metal. And you see she wears high shoes, so there's heel contact. You see increased knee flexion in loading response. It's not influence, but in terminal sense, you see that the vector drops to the toe because of the rigid foot plate. And because of that, you see now full knee extension and hip extension in terminal sense. So the trick is that you move the point of action of the vector more ventral. Yeah. So this is the loading response. You see the loading response is not influenced by the insole, but you see now the vector drops to the toe and it moves forward, and because of that it's more ventral from the knee, you increase the knee extension moment. And that's why she gets full knee extension in terminal stance. I think, is that clear to everybody? So when you give a rigid insole, then you increase the knee extension moment in terminal stance. Okay, I see no questions. Well, any type 4, we have a special designed AFO. I like to show you. The AFO in the Netherlands cost €2,000 each. But even in Indonesia, there are very rich people, so they can afford it. And Otto Bock is providing a good quality of a carbon bar on the backside of the AFO in combination with a carbon footplate. Yeah. So the footplate should be also stiff. Well, you see, he has no full knee extension in terminal stance and increased flexion in mid stance. And here he's walking with the ankle 7. And you see the vector drops to the tip of the toe, and you see an increase of knee extension in terminal stance. Well, the ventral AFO I showed you has the same action. Yeah. But there is a difference. Well, you see, he can run very quickly with this AFO. Yeah. And that's not the case with the ventral AFO I showed you. And when we look at slow motion, you see that the bar at the backside, is loaded in mid stance and support the push off, and that's why he is really able to run with the ankle 7 AFO. So the trick is that the bar in loading response is bending, and it acts as a spring, and it supports the push off. And I don't know if you have seen the blade runners with prostheses. They run faster than normal, healthy humans, and that's because of the same mechanism that the spring is loaded in loading response and support the push-off power in terminal stance and pre-swing. Here you see the effect. Well, children are very happy with this kind of AFO, but they are very expensive. Yeah. And I have a question. Did someone of you ever seen this kind of AFO? Question to everybody. Yes or no? I see one yes. Regina, you have seen this AFO before. Okay, not yet. Yeah. Okay, that's very special. Regina, where was this AFO made? In Jakarta or in Singapore? Oh, in Thailand. Okay, okay. Yeah, okay. That's very interesting. Yeah. Is it the same mechanism as posterior leaf spring? Yeah, but in a posterior leaf spring, I think they don't have a full rigid foot plate, and also the spring is much weaker than the carbon. For you have to, the stiffness of the carbon bar is related to the body weight. So posterior leaf spring, could have the same action, but you have to make it with a rigid foot plate, for otherwise it doesn't work, and it's not strong enough. Well, the question about spasticity. Well, spasticity is stretch reflex. Yeah. And when you fix the foot, well, you see some movement, but in the ankle, so you get some stretch, mainly on the soleus muscle, yeah, in loading response, but not that much, and you don't get a specific stretch of the gastroc. So keep in mind, below knee is soleus, and above knee is gastroc, and spasticity is only stretch reflex. It's not magic. So when you look at him in running, you don't get specific stretch, and in just walking, you get stretch of the gastroc by knee extension. Here, you get stretch. So when you have a high level of spasticity or shortness of the gastroc, then the knee extension will be blocked. And yes, then treatment of the gastroc can help. Mostly it's shortness of the gastroc. You must realize that I show you that the gastroc actually is important for the push-off power. So weakening the gastroc is not without any danger. I will show you in the next type. So surgery of the gastroc actually destroys the gate mechanism. Yeah. So you have to be very careful in weakening the gastroc. What's a better solution when you don't get full knee extension with a ventral AVO or with this ankle 7? That you give 2-week serial casting. You give below knee cast, but with a rigid foot plate till the toes. And then you give daily physiotherapy in training and standing and walking. And the cast has 2 mechanisms. At first, you reduce the spasticity by reducing the sensory input by the cast. Yeah, when you put it in a cast, you reduce the sensory input, and that will reduce the spasticity of the gastroc. So the first week, you don't have to correct much for the muscle length, but the second week, the gastroc is more relaxed, and then you can increase the range of motion to dorsiflexion and let them walk a week with again with the cast, and then you have increase of range of motion, and mostly then you get full knee extension in terminal stance. I have published research that in which we demonstrated that increase of range of motion of the gastroc will improve knee extension in walking. When you look in PubMed on my name, you can find that publication. Yeah. So it's a good question. But it's better to give the AFO and look what's happening. And when you don't get full knee extension in terminal stance, then you can add serial casting 2 times 1 week and then proceed with the AFO. And mostly you get then full knee extension in terminal stance. Okay, that's a good question. Are there other questions? No? Okay. So keep in mind the ankle 7 for your rich patients, and the children will be happy. There's only one thing, they may not jump with this AVO. Yeah? I had the one child, he jumped with the gymnastic from a height on the floor, and then buff, both were broken. 4,000 euro. Yeah? So don't forget to tell them that they are not allowed to jump with the AVOs. Okay, well, gait type 5 is knee flexion in terminal stance and mid stance with full foot contact. And you see here, there's an increased knee flexion in loading response. In mid stance, there's still knee flexion. And in terminal stance, there is no full knee extension. Yeah? And this can be due to soleus weakness, also gastroc weakness in terminal stance, or in combination with hamstrings hyperactivity. Yeah? For hamstrings are flexors of the knee, and they can block also the knee extension in terminal stance. When you look to the ground reaction force, you see there is only a weak acceleration in terminal stance. Yeah. Well, to tune this gait type, you have to control from initial contact to mid stance the knee flexion, and from mid stance to terminal stance the knee extension. And you can use a ventral AVO. It's a rigid foot plate, but with a hinge, when you can control the degree of dorsiflexion and the plantar flexion stop. And within the hinge, you can add a spring. So there is a spring on the ventral side, and there is a spring on the dorsal side. Does somebody ever have seen this kind of joint for an AFO? I like to see yes or no's. No. No. Not yet. No. No. Even Regina hasn't seen it. No. Okay, that's totally new for you. Yeah. Okay, I think Otto Bock makes now also this kind of joint. They are on the market. And in Holland, we use this is made by Fior and Gens. It's also a factory from Germany. I don't know if they are available, but Attebok is working in the Netherlands. Well, when you see as the effect of the AVO that you can control the whole gait cycle. When you look to the ground reaction forces, the vertical component, you see a complete correction of the vertical force. So in initial contact, you get heel strike, and you can control the degree of flexion of the tibia in loading response. It's still somewhat increased, but in terminal stance, you see that you get full knee extension and hip extension, and it supports the push-off because of the rigid foot plate. So you can nicely control both the loading response and the terminal stance. And you really need to have to make videos to look to the effect, and you can adjust the spring till you get the optimal figuration. Okay. And you see when she's walking at normal speed that she can walk quite good with the AVO. You see, it's a good walking speed. Okay. Well, I said to you that the voluntary force of the gastroc is very important, and I like to show you what can happen after Achilles tendon lengthening in bilateral involved children. You see this boy walking with excessive dorsiflexion and weakness of the soleus and the gastroc. And you see it's a very bad way of walking. And all the orthopedic surgeons and parents are complaining about toe walking, walking in plantar flexion. But you can better walk in plantar flexion than you walk on this way with full foot contact. But this child will end up in a wheelchair in time, while when he didn't get surgery, he should walk as an adult on his toes. Yeah. So it's really a disaster all over the world that they do the Achilles tendon lengthening in young children. But imagine when you are 4, you have a low level of body weight. So when you lengthen the gastroc, okay, they walk on flat foot. But when they get older, they gain in body weight, and especially in adolescence, then they get a problem. For when you do surgery to a muscle, that's to any muscle, you reduce the voluntary strength with 50%. And it's also research is published from Martin Guff from the United Kingdom. They measured the voluntary force of the gastroc, and they showed that you reduce the voluntary force with 50%. So when you are adult and you have 50% of your voluntary force of the gastroc left, then you get this gait type. And that's awful. Yeah. I let you feel at the beginning how it is in standing with flexed knee. So you can imagine how this type of walking, how much energy it costs. Yeah. And well, you can try to correct this gait type with a ventral AVO, but only is it possible when you have less than 20 degrees flexion contracture of the knee and the hip. When you have more than 20 degrees flexion contracture, it's impossible to get the vector before the knee. You can reduce the flexion, but you don't get it to extension. The only other solution is multi-level surgery, and that for this boy, that will be psoas lengthening, hamstrings lengthening, knee extension osteotomy, and triple arthrodesis of the ankle, bilateral, and then proceed with the ventral AVO walking for the rest of his life. For you can't give him back the force of the gastroc and soleus. So I hope that you keep this picture in mind and make objections to a proposal for surgery of the gastro. What's much better to treat it shortening of the gastro, real shortening with the serial casting, for that's a harmless uh, treatment when you prevent pressure sores. So it need to be done technically properly, but it's much safer than surgical treatment. And you can add some botulinum toxin for temporary weakening. But even with botulinum toxin, you can achieve this gait type when you repeat it every 3 months. Yeah. So weakening the gastroc is really harmful on the long term. And even with a repeated botulinum toxin treatment. Yeah. The rehab doctors in the United Kingdom became mad of all those pediatric neurologists who only were injecting the gastroc every 3 months with botulinum toxin. The child will end up with this gait type. And I have a question for you. Who of you have observed this gait type in children after with gastroc lengthening in the medical history? And I like to see yes or no's. Who have seen this? Did you see this before in a child? Yes or no? After surgery of the gastroc. I'm curious. Yeah, question to everybody, yes or no? A lot of no's. Okay. Okay. Yeah, that could be two possibilities. You haven't seen much bilateral CP children, or the orthopedic surgeons in Indonesia are much wiser than in other countries. I hope the last. But I hope you will remember this for the rest of your life. Okay. Well, then the next subject is, besides the correction of the gait, an AFO is also meant to correct foot deformity during growth. Yeah. For when you don't correct during growth, then you get adaptation of the shape of the bones to the deformity because of the growth. And if any surgery is needed at the end of growth, then surgery is much more difficult. So the purpose is to keep the foot flexible and to guide the growth till the age of 10 to 12. Yeah? When increasing body weight, there will be an end to the possibility of foot correction, but in young children, it's very good possible. Don't do this with adults, for you lose your patient. They don't like you anymore. Well, the most common deformity is the valgus of the calcaneus with talonavicular subluxation, abduction of the forefoot, and exorutation. Now, you're familiar with this, I presume. Yeah. Well, at first you can correct the valgus position of the calcaneus in your AFO with pressure points located at this side, so on the lateral side of the calcaneus, medial above the medial malleolus, and lateral just under the head of the fibula. And almost no AVO, dorsal AVO, has these pressure points for foot correction. And especially in off-the-shelf made AVOs, it's lacking anyway. But also in the most of the custom-made AVOs doesn't have pressure points. So you have to make flaps on the lateral side on these positions for a proper correction of the valgus of the calcaneus. Yeah. Well, within the AVO, you can correct the valgus with a 3-point pressure system with these points, and the pressure should given on the calcaneus and not on the talus, for that hurts. And on the distal, it should be at the shaft of metatarsal 5 and not on the head, for that will hurt. Yeah. And besides the 3-point pressure system, you can use the ground reaction force for medial support of the foot. But it's important that you start the support at the head of the calcaneus and not on the talus, for that hurts. Yeah? And you need to use the whole surface of the foot arch, for then you can divide the pressure over the skin on a greater surface. And that's much more comfortable, like this way. And you can check the support of the foot arch by let the child standing on one leg with hand support for 10 seconds, and then put off the AVO and you can see a red flush of the skin which is loaded. And on this way you can check if the whole surface of the foot arch is used for correction. Yeah. Well, I see everywhere only flat foot plates in AVOs, and that's not correct. Yeah, you should use the AVO for correction of the foot deformation in barefoot. So on Monday, you will start a new life. Well, the varus is the opposite way around. The annotation and adduction of the forefoot. And varus gives more pain than valgus. Yeah, so varus correction is really needed. Well, in varus, you have the opposite place of the 3-point pressure system. So on the medial side of the calcaneus, lateral above the malleolus lateralis, and medial at the under the knee. And the same in the transverse plane in the foot plate. And important is to put this pressure point before this proximal from the head of metatarsal 5, for that will hurt, and before the head of metatarsal 1, the distal head, for that will hurt also. Yeah. And when you to give the support with the ground reaction force, you have to give a pronation, but just before the proximal head of the metatarsal 5. For otherwise it will hurt. Yeah? So this is the place where you can give correction, and you can imitate it with pressure of your thumb on the foot. A varus correction is very important, or that gives the most complaints and of pain and callus formation on the foot. When you correct a plantar flexion in AVO, you need to have a good fixation on dorsum of the foot. Yeah. So using the laces is not correct, for the forces are so high that the heel will lift within the AVO. Yeah. So these are the correction points, and you need a firm closure around the ankle. Yeah. So in summary, I presented the classification in 5 main groups of gait, and the degree of foot deformation, muscle shortening, and joint contractures are modifiers for therapeutic measures. So clinical assessments are essential information, and the classification offers a frame for decision schemes for therapeutic interventions. Okay. Are there still questions?
After the case presentation, Professor?
Yeah, that's okay. I don't know if somebody has a question at this moment.
Any question from the participant?
No
Any
questions?
question?
Okay. Everybody is speechless. Okay, then we can proceed with the.
Yeah. Okay.
Uh,
The case presentation, Professor.
yeah. Okay.
Okay. Okay. Thank you, Professor, for the lecture. It's difficult, but it will change how we give effort to the patient. Next session is
Thank you.
a case presentation by Dr. Sakina, our resident from PMR Unpad. So, Dr. Sakina, time is yours.
Okay. Thank you for the time. Thank you, Professor, and thank you for Dr. Marita who introduced me to the professor. So today I would like to share about my case with the title is Improving Functional Mobilization in 4 years old cerebral palsy dyskinetic patient with unilateral hip displacement who refused operation. Then today we have Kaisa. Kaisa is 4 years old and 4 months old. Was referred from pediatrician with cerebral palsy spastic diplegic. The first examination is on September 13, 2024. And chief complaint is unable to stand up and walk independently. So this is the history of present illness. This is the video of the family of the Kaisa and her mother. From the videos. And from the video, the Kaisa said that she really would like to walk independently because Kaisa would like to have buying some snacks independently, attend to school, and also playing with her friends. And also her mother said that she really would like Kaisa walking independently to make her become independent in the future. And after that, the Kaisa already conducted hip X-ray examination since 2 years old and suggested the operation for hip displacement, but her parent refused it since the beginning. Okay, and this is the anamnesis from the history of birth. She was born from a mother who was 36 years old. The child was born prematurely at 28 weeks of gestation by OBGYN at Hasan Sadikin Hospital via vaginal delivery due to premature contraction with the history of vaginal bleeding in 27 weeks of gestation due to placenta previa. Birth weight is on 1,050 grams, body length is 38 centimeter. Did not cry immediately after birth and she using ventilator for 3 weeks and subsequently hospitalized for 60 days without any history of seizure. And this is the present illness. So the Kaisa already diagnosed cerebral palsy since 2 years old, and since then she began rehabilitation program in PMR outpatient department Hasan Sadikin Hospital. The improvement was good. After 3 months of rehabilitation program, she able to sit independently by side lying position. It is in July 2024. Then after that, the patient still unable to do independently shift from sitting to standing position, need help by the caregiver or hold on to the object to lift up her body. She can sustain a standing position with support and can walk by holding to the caregiver or cruising to the furniture at home. However, she is unable to fully extend her hip and knees while lying down, standing, and walking. From the very first time she learned to walk, she walked with tiptoe, and until now she never been able to walk independently. Patient had the story of falling when she was 3 years old from the chair. Since then, patient not confident to sit in a high chair without any support of the handle. So this is the beginning when I saw Kaisa the first time. We can see from the posterior side of the patient that the patient is walking with the plantar flexion. Then the knee is the hip adductor is very high. Then she can her quadricep also weak. Then next. Then this is the fundamental of the history, and there is no taking any medication yet. And this is the psychosocioeconomic status. The child can play with her big sister and friends with the same age. Otherwise, her mom noticed sometimes she looks upset while her friends playing hide and seek, crying, and etc. For the social status, the primary caregiver is the patient's mother, and the economic status is from low income category. So this is the home condition in this patient. The patient's house is on the alley with 60 centimeter apart. From the front door, we can see there is the barrier with 40 centimeter height to prevent flooding. So the patient should bring up by her parents to come into the house, and she is often to stand and holding to the wall while bathing. And the hope from the parents is she can be able to walk independently without surgery and go to school. And hope from the child is able to walk independently so she can play with her friends and buy some snack by herself. So we have a goal. So she can walk independently, play with her friends, and also going to school. We can see from the postural examination, during the examination, the patient have to hold to her parents to maintain his standing position. And from the ankle, we can see is in tip to standing. Plantar flexion and inversion is more higher in the right side rather than the left side. And also we can see there is a valgus calcaneus sinistra. And from the knee is cannot fully extended. So the hip also, hip adductor is very tight. And the hip is posteriorly to the knee area. So the center of gravity in this patient is posteriorly from the base of support. So the Kaisa is easily to fall. And also we can see there are a hip discrepancy. And there are because of the discrepancy of this hip, the trunk have a compensation to bending to the left side and compensate by the head and cervical region to the right side. And this is the cognitive function of the patient. We tell Kaisa to counting 1 to 5, and Kaisa is able to do it. Next. And this is next. And this is the identification ability of the patient from her cognitive. She able to know which one is bigger, which one is smaller, and which one is taller, and which one is shorter. Then after that, I give Kaisa color. So she can identify color correctly. She's in pink, yellow, blue, orange, and red. Okay, next. Then we have a hand function in this patient. First time I tell the patient to do the pinching, but if we identified in this video, she cannot do tip to pinch, which is pinching by the tip of the thumb and her index finger. But otherwise, use lateral pinch, which is pinching between the thumb and the radial side of her index finger. And after that, I tell her to do spherical grasping from the left side and the right side. And also the, still spherical grasping. I would like to see the motor power of the finger area. Then, sorry, Professor, I tell her to do the cylindrical grasping from the left side and the right side. During this hand function video, we should see how the movement of the hand and the facial face in this patient. Okay. Then this is the lateral grasping. She is able to do the lateral grasping. The left side is more better than the right side. Okay. That is the handwriting skills. She already trying to tripod grip, but her tripod grip is not good enough. So it is not, the grip is still dynamic. Then next. Then I tell her to do the reaching, then do the wrist extension, wrist flexion. And if we can see, there are some involuntary and uncontrolled facial muscle movement like grimacing. Like as I tell before, the patient have revert by spastic diplegic, but we think there are some mixed cerebral palsy type in this patient because of the involuntary movement. So we think that he have a dyskinetic. So this is upper extremity examination. She have some spasticity on the elbow flexor of the right side, nor in the left side. So this is the lower extremity examination. I try to examine for the hip flexion movement and do the Thomas test examination for looking of the iliopsoas tightness. So if we can see, while she's trying to extend her left side, the knee cannot fully extend because of the tightness of the iliopsoas muscle. Then I check for the range of motion of the abduction. The range of motion of hip abduction is more greater than in the left side rather than the right side. Okay. Ini play aja. Then this is the lower examination in the prone position. We can see the range of motion of hip extension. The hip extension range of motion is greater in the left side. Then we check for the, we check for the internal and external rotation, but sorry, I have some mistake here because I'm not palpate or fixation at the greater torsion.
And it's for the anteversion. Okay.
Yeah. Then if we can see, there are some tightness on the quadriceps because it is the Eli test positive for the both of the extremities. Then I check the spasticity. There are some spasticity in the knee flexor with the +1. Then continue for the thigh and to inline examination. We can see from the hip, knee, and ankle, it's not symmetrical inline because there are some spasticity of the adductor region. Next. Then we check for the hip discrepancy examination. Now I examine to be by the tangensial angle of this patient. I check it for the length of the iliaca superior, then measure the tangensial of the SIAS. Then I get the 12 degrees and counting how long is the discrepancy of the hip. Then if we measure it by the tangensial angle, it is 3 centimeter difference. So I give some 3 centimeter support on the left side of the lower extremity and make it 0 degree of the hip discrepancy. Next slide. Then after that, I check for the judgment of force. Initially, I would like to check the judgment of force during squatting position, but the patient cannot do squatting position. And during the squat to standing position, this is the ability that the patient can do. So the patient have to hold to her mother and give some power by her upper extremities. And from like side lying, then she is standing. And this is current mobilization. If we see that the patient not using any brace or shoe, we can see their tip 2 and the hip extension in the right side is not bigger enough than the left side. And this is the mobilization by the shoe lift and the brace that I give to her. Next. Then this is the supporting examination. As I told before, in the 2 years old, the patient have already hip discrepancy by migration index is 54%. Then I check again in January 24, then the migration index is increasing for 59%. And during the January until August 7, 2024, we give some rehabilitation for walking, but migration index is increasing into 81%. From the first examination in 2022, we already told the patient and the family that we suggested to do the operation because of the displacement of the hip. But the patient and the family still reviews, and then we have to think what kind we can do because of this migration index is becoming heavier. Next. So the diagnosis of medical diagnosis is cerebral palsy dyskinetic with gross motor functional scale is 3, ACS2, CFCS3, IDEX1, and hip dislocation. With the functional diagnosis is locomotion, fine motor, social activity disturbance. But for the prognosis, for the ad functionem, I make the prognosis is walking independently using walker, able to do binual activity for ADL, and can play with her friends and mobilize at school independently. Next, so this is our plan because we have some problem because of the spasticity, joint stiffness, and muscle weakness, also hip dislocation and hip discrepancy. So I would like to give some intervention. From the beginning is in the spasticity, joint stiffness, and also muscle weakness. We give some shock wave therapy and hamstring and adductor bilateral so the spasticity can be reduced. Then also give strengthening exercise and flexibility exercise. Then after that, for the hip dislocation, I give some intervention by the journal in 2022. This is the efficacy of hip brace for hip displacement in children with cerebral palsy. But in this journal, the cerebral palsy that mentioned in this journal is in level 4 or 5. With the result is significantly but significantly decreased in the group wearing hip brace for the migration index after 12 months of the using of the brace. So we adopt this journal to give brace for her, which is his on a gross motor functional scale 3. Next, this is the brace that I give to her. So we have 3 main points of the brace. the A point or the upper straps were designed to hold her pelvic to give some support for hip abductor region, so her hip discrepancy could be maintained and protect hip joints from displacement. And for the B side, this is the round design, which was applied at the buttock area to allow comfort when sitting and to prevent movement of the orthosis. And the 4C is a tie straps were designed to prevent hip adduction. So this is the result of the hip Ronson examination. As we can see, the migration index before is 81%. And this is the current condition during the same standing position during the examination and using the hip brace. So the migration index in this patient becoming 66%. And this is for the hip discrepancy and postural disturbance. As we can see in the beginning, there are hip discrepancy that makes him can be a scoliosis in the future. So we should give some intervention in this hip discrepancy. So I make some outsole and also postural exercise so she can know that she have to fully knee extension and hip in neutral position. Then after that, this is the postural examination after I give the intervention. From the left side, there are without brace and shoe, we can see that the adductor of the hip is very tight and the knee is kissing between the left and the right. Then after that, I give some brace, but still without the shoe lift, that the discrepancy is decreasing because of the abductor region that holds by the brace, and the adductor is also get some tight because of the brace. And the third picture is with shoe lift, so the hip discrepancy becoming natural. Then after that, for the activity, because of she cannot do independent mobilization, I give some gait training with partial weight bearing treadmill to give some ability to move during walking. Then also walking exercise with reverse walker. Then this is the current condition. We have 4 videos here. On October 2024, that was the beginning of the Kaisa trying the walker. In the beginning, we can see that the Trendelenburg is very visible in this patient because of the weakness of abductor region and very spasticity at the abductor region. Then in November 2024, after 1 month, the patient already trying to do the hip flexion movement during stepping, during the walking. Then in November 2024, in November 2024, I give the brace is already give to him, and he already have the shoe, and I also give some cueing during the exercise, and she can follow the instruction. And in February 2025, she already can able to do the mobilization independently by her walker. Then this is from the sagittal side. In October 2024, we should still holding her because she cannot grasp the walker, and she still cannot control the walker. And in November 2024, she's trying to stepping by the cueing, and February 2025, she already can do mobility independently. So this because of the participation is she's still unable to play with her peers and going to school. And the future plan for increasing mobilization ability is increasing motor power of upper and also lower extremity to be able turning with walker, so she can do mobilization more independently. And also we plan that we give some AVO modification, like maybe you mentioned before of the ventral shield of the AVO because there are knee flexion. I think we would like to discuss it also. Next. Thank you.
Thank you, Dr. Sakina, for the presentation. Before we begin our discussion, I would like to invite Miss Lydia to give some presentation. Lydia?
Okay, thank you. Can I share? Okay,
Yes, betul.
yes. Okay. Okay.
Would you like us to help with the presentation?
I have here. Can
Oh, yeah.
listen? Okay. Thank you. Thank you, Professor Jules, Dr. Mareta, Dr. Irma, Dr. Sakina, and Dr. Jaka for the time. I would like to share my inputs with the children, with the child. Okay, this is this suggestion for device roadmap. Because she can progress to independent ambulation with mobility assistive device and can still hold assistive device albeit slow. My mobility assistive device road suggestion is posterior walker with padded lateral and posterior support, reciprocating walker that can function in both 4 legs and 3 legs, padded Canadian crutch with 4 claws, and for the orthotics, for the orthotics, I think it needs some grapho, ground reaction force AFO, maybe because it's type 4, from what I've seen, and she has no correction at all in the terminal stance that is still flexed, and also and I will concentrate for the assistive device. So I think for this walker, addition of lateral pelvic support is needed to stabilize the hip, and may need to have posterior pelvic support too. Okay, this is additional orthosis I mentioned with grapho, and also the correction in the lateral side, and maybe if possible can add a swash, sitting, walking, standing hip orthosis, but it doesn't need to be connected with the AFO. And after after the child managed to do the walking with a walker that has wheels, and correction with the AFO, grapho, or what you said, ventral, another grapho or ventral, and because the walker with wheels will be very limiting, I would suggest a reciprocating pediatric walker for more independent ambulation in more terrain, and it's to fit the size and the function of the child. And the reciprocating walker is modified so that it can be used as both as 4 legs and 3 leg walker, because when we have 4 leg walker and we have uneven terrain, it cannot support correctly because one of the leg is suspended, and with the slight modification of the reciprocating walker to have a more advanced angle, and it can be used as a 3-leg walker and can be used to climb up and down slide ramp. For example, this is the okay. So the angle is much more forward. Yeah? This is just the demonstration on how the walker reciprocating walker is modified so that the angle can be used to have three point support in the uneven terrain. Okay. Okay. This one is after managing reciprocating walker, I would suggest to have Canadian crutch with claws. For example, this is the child that have Canadian cane, but with claws to stabilize further. It has four claws, and she has been using this for years actually, because she's bunny hop and cannot be corrected at the. So she can independently walk using this. Okay, and when she can master Canadian crutch with a claw successfully, it's time to change the tip of the crutch with a single rubber. For each crutch, it would need to have a slight pivot and twist to accommodate slightly uneven ground and steeper ramp on where she lived. The other possibility of the previous one, the walker, needs to have a ground clearance more because the house has a slight in front of the house there is barrier for the flood. Okay, so this is my I made this presentation before hearing the whole presentation only by seeing. So the mobility assistive device roadmap would be posterior walker with padded and lateral posterior support, a reciprocating walker that can function both in 4 legs and 3 legs, padded Canadian crutches with 4 claws, and then padded Canadian crutch with all-terrain hip. But this is it has to be combined with the correct use of the orthosis. Thank you.
Thank you, Lydia, for the presentation and suggestion for this patient. Before we ask comment and suggestion from Professor Jules, is there any question from the participants?
Yeah, I have still a question. And I missed it perhaps, but what was the passive knee extension on both sides?
Okay. Passive knee extension.
For the passive knee extension in this patient is full extension.
Okay, she can get full knee extension. Okay.
Yeah. You want to see the video of examination, Professor?
No. That's okay. But when you say so, I believe you. That's
Okay.
important.
Yeah.
Okay, Dr. Irma, you have a question?
Ya, halo Profesor Jules. Thank you Dr. Mareta. Halo Ibu Lydia.
Halo Dr. Irma.
Yeah, okay. Okay, since I'm the examiner for Sakina's case, and there already have been many comments regarding the orthotic and assistive device, so I will ask question outside the scope of prosthetic. So let me ask Sakina about this question. The first one is what can rehabilitation do without surgery to maintain or improve the patient mobility function in the long term? So whether rehabilitation can help to maintain or improve the patient mobility in the long term? That is my first question. And then the second one is the use of the hip brace and walkers effective enough to prevent the worsening of hip dislocation in this patient? And then the third one is how can the patient mobility limitation impact the psychosocial development, particularly in playing with peers and school readiness in the later on? And the last one is about the you use the ESWT to improve the ROM and also reduction the spasticity. So how significant the improvement by using the ASWT, and then is it substantial enough to support the patient mobility? Thank you, Dr. Marita.
Yeah, okay, there are 4 questions.
Yeah,
Please,
thank you.
Dr.
Thank
Sakina.
you for the question, Dr. Irma. So, the first question is the rehabilitation without the surgery. So, the surgery that I mentioned to the family is the surgery of the hip dislocation in this patient, because from the journal of the previous study, if the patient of cerebral palsy have migration index of the hip more than 50%, so we should give some interference to do the operation of the hip, because if we just let it on this patient, maybe there are some pain or some limitation of the range of motion. So if the family refuse of the surgery plan, so we should think that what kind of things that we can do that the patient can still walk independently, but our programs cannot make worsening of the hip migration index. So I think we should make some brace to hold on the hip displacement in this patient. And I looking for the journal that mentioned about the hip brace for the cerebral palsy patient. As I mentioned in my presentation, there are the journal for hip brace that used for the cerebral palsy in GMFCS3 and gross motor functional scale 4 and 5. And from the result of the journal, that the migration index of the patient is not increasing if we use the brace in every day for 12 months. Then because of our patient is in gross motor functional scale 3, I think we can provide and give the brace also to give some hold to the hip, so the migration index cannot worsening due to the exercise. Then the result is in my presentation. Sorry, I would like to share screen again. Okay, sorry, Ronson. Okay, sorry for the time. Sorry, yang Ronson ini di bawah. Oh, boleh. Yeah. So this is the radiological examination after I give the brace in this patient. In the and superior side is on August 7, 2024. We can see the migration index is 81%, which is the femoral head of this patient already displaced. Then I give the intervention of the brace. Then the lower radiological examination is using the brace. Then we can see the femoral head becoming closer again into the acetabulum area. Then the migration index is 66%. Even though it's not less than 50%, but we can see that we still can hold and even getting better in the migration index. Then for the
can trigger the worsening of the hip
yes,
dislocation.
yeah, doctor. Then after that, for the second question, is it the hip brace and walker can make mobilization? Yeah, doctor, sorry.
Effective enough.
Effective enough to do the mobilization in this patient? I think yes, because before we give some hip brace and also walker and also the shoe lift in this patient, the patient cannot do walking independently, because the patient have to hold to something like cruising or holding to her parents to do walking. See that the patient can do walking independently even though it's using walker. May I play again the video? Yes. Sorry, doctor. I would like to share screen again. Belum ke share screen. Sorry, doctor, belum ke share. Oh ya, belum ke share. Yeah. And the first video during the first time I saw her, yang ini dong, sorry, bukan. This is the first time when I saw her at the rehabilitation outpatient clinic. So if we would like to make in erect position to do mobilization, we should hold her hands, then she can able to walk. Then after that, we give the intervention by using walker, by using the hip brace, and also the shoe lift. So now in February 2025, she can do walking independently using the walker. Even though the gait is not correct enough, but we can see that the difference from the October 2024 until the February 2025. The step length is increasing, the hip flexion movement is increasing, the knee adduction movement is also lowering. Yeah. Then for the third question, for the social impact, I think if the patient or the children cannot do walking mobilization independently, it's very give some social impact in this patient, because we all know that the children, the task or the function of the children is to play with her friends. So if the patient cannot do walking, cannot do running, it will very impact the social life in this patient. And for the fourth question about the shockwave therapy for the spasticity in this patient, I interfere the patient in the adductor region and also the hamstring region. The difference before and after the ESWT for ESWT for the once a week in 4 months, not very significant, but can lowering the tone of the spasticity.
Okay, so do you think that compare with other methods such as botulinum toxin or serial casting, the ESWT is considered primary modality or only supportive therapy?
It's just on. I think it's just only supportive therapy because the intervention for the spasticity that I give is to lowering the tone of the adduction moment of the hip to make the decrease of the tone of adductor, so the displacement of the hip can be interference also because of the tone is decreasing. And also I interfere at the hamstring area to make the knee flexion moment in this patient is also decreased. So the point that I give is to make the posture of this patient can be better before the interference. Yeah.
How long will you give the ESWT, Dr. Sakina?
From the beginning until now, it's already 4 months, but I think I would like to stop it in the 6 month because from the third to fourth, it's not changed significantly, and today the patient already can know how to how to stepping during the walking, and also during the step during walking, because the main point of the decreasing of the spasticity, I would like to give the walking ability to making the gait is improved.
Okay, Dr. Reta, thank you. Thank you for the answer.
Thank you, doctor.
Thank you, Dr. Sakina. Prof,
Yes.
you like to give a comment?
Yes.
Please.
Well, at first about the diagnosis. Yes, you are right that there are some dyskinetic signs in hand and mouth region, but you have to rate it according to the dominant type of motor disorder, and this is spastic. So she has a spastic diplegia, and on the right side more than on the left side, with some signs of dyskinesia, but that's almost always the case. So keep it on spastic diplegia. Well, I think that's important for the diagnosis. And then I have a question. Is she able to walk on her knees?
She's not able.
No, she's not able.
She's not able.
Can she hold the position of high knee position?
High knee position. So in high knee position, like in the video. Sorry, Professor.
Yeah, no, in the video I saw you trying squatting, but
but
she
she
was
cannot
not.
do squatting. No.
She fell down. Well, actually, she showed extension force,
Di itu
but
dulu.
but
Sorry, Professor.
she couldn't hold.
Then this is the video from the
Squatting.
Squatting, but she cannot do squatting. Then when during the standing, there is the motion in this patient.
Yeah,
But she cannot do high kneeling.
Yeah, but now she's on the feet, so I don't see high kneeling.
Yeah.
This is high kneeling is when you are standing on your knees.
Yeah, I try in the examination. I tried the patient to do the high kneeling, but because of the spasticity, she cannot do the high kneeling position. As we can see during the as we can see during the video, from the floor to the standing, the spasticity of the adductor region is very quite high. Then the patient have to like give movement from the side lying to the upright. And if we see for the high kneeling, she cannot do because the position in this patient is going to the right side. So
Now
that
you didn't show high knee position for she's all the time on the feet. So that's a real different and don't talk about spasticity. For spasticity is stretch reflex, and this has nothing to do what you see with stretch reflex. It's the motor control, the synergistic movement, so the ability to have dissociated movements is important, and the strength, for she's weak in the especially in the right hip. So the hip abductor weakness is a major problem for her, and has nothing to do with spasticity. And high knee position is actually the best way to look at the voluntary force when she is sitting on the knees and coming up from flex knee position on the floor to high knee position. And that's also good exercise to train the hip extensors and hip abductors. So that's why, and I didn't see it on your videos. So the squatting was not possible as she couldn't hold in totally flexed knee position of hip and knees, but she had the force for extension. For I didn't think the mother was pulling her up, but she couldn't manage the position. So my advice is to at least look at if she can sit with flex knee and then raising to high knee position, and it's anyway a safe exercise for her, for the hips, for the hip abduction weakness is her major problem in walking. So that will be a good exercise for strength training for her. And I had another question. You could treat the adductors with botulinum toxin to change the balance. Did you do so? I don't know. I'm not sure.
Oh, we don't do the Botox injection in this patient.
Okay. Yeah, I don't know if it's a matter of money for I think they have to pay the botulinum toxin themselves. Yeah. So
Yes.
yeah. So that's not really an option. Yeah, in Holland in the past, before the botulinum toxin, we did it with phenol injections in the adductor nerve and in the branch of the adductors to reduce the tension of the adductors. For the tension in the adductors is also a problem. And for future, that problem will not disappear only when the hip abductors are getting strong enough. Yeah. So the risk for the hip when you see them walking with the pelvic lift on the right side because of the abductor weakness, that is a bad sign. So that's related with the hip lateralization. So I think your hip abductor orthosis is a good idea, but for walking, I think walking with canes is for the hip much more risky. So I think with the walking aids, look what's happening with the pelvis during walking. And when she showed the pelvic lift because of the weakness, then you know that that's not good for the hips. So in observation for what's the best walking aid in her home situation, I should suggest try it out and look what's happening. But I think canes are at this moment too difficult and too risky for the hips. Yeah. That's actually my suggestion.
For the walking aid, the posterior walker is still suitable for this patient, Professor?
Yeah, that's was my preference for that promote extension. But yeah, looking to the home situation and how she can move around, yeah, that's difficult. I think it's important that she can move around at home and in the environment. For the more she walks, the stronger she will be. But you must observe in which walking aid is the most suitable and safe for her. Eh? So I can't predict it from my position. So it's nice that you show the picture of their home, and I think you have also to look to the environment and to the road to the school and try out what's the best and safe walking aid for her. Yeah.
Okay. Thank you, Professor. May I ask something?
And it was a nice presentation that you
Professor.
showed. Yeah.
Sakina want to ask something.
Yeah.
Okay, thank you,
Yeah,
Professor.
Sakina.
I would like to ask to continuing the ability for walking. Is it better if we give some ventral AVO in this patient, or just in with this current condition? Thank you.
Yeah, I think as she can have full knee extension, then a ventral AVO is preferable as she's walking with flexion. You can give her some days below knee cast with a foot plate till the toes to try out. Yeah, and look if she's able to walk. It's somewhat more difficult, but when you give it a week, then she get used to it, and you can give it a try out before you make such orthoses. For yeah, it's expensive, and then you get an impression if she's able to manage or not. Yeah.
Yeah. Thank you, Professor.
Okay. We still have one question. Oh, Lydia, you want to give a comment?
Yes. I would like to suggest as well to stand with knee supported to something in front of the knee, some padded support in front of the knee, and to try to stand in that position and see if it can help to extend the knee. So you put
the standing frame you're suggesting?
not the complete standing frame, only partial standing frame with the knee, something to hold the knee backwards.
Yeah, but a ventral AVO will do so. I
Yes.
showed in my presentation. I give never something around the knee. Never. It's not needed. You can control the knee from the AVO. Yeah. There's only one indication for a CAFO or something around the knee, and that's in ataxic CP with hyperextension of the knee. That's very difficult to control from the AVO. But in a spastic CP, I never give a device around the knee. You can
Sorry.
control everything with the AVO.
Yes. What I mean is not the one that is wearable, but you put the thing under the knee is for the exercising. The
For stretching exercise.
yes, to stand up more easily before making the
Stretching
ventral.
exercise in standing position.
Yes,
Stretching exercise in standing position.
yes, and doing activities there. So you push the tibia backwards.
Yeah, but it's better to train the soleus and gastroc, for that's always overlooked. But when she's
see.
stronger in the calf, then it's also easier to control the knee. So
see.
besides the hip abductors, you can also train the soleus and gastroc to make them stronger. For that, that's very important, crucial for walking. Yeah,
Yes.
and
Okay.
most are focused only on the spasticity, but not on the voluntary strength. Yeah, that's different.
Yes, yes, yes.
Is there any other question? From the we have one question from Dr. Asadi. Into Dr. Sakina, in what way do impairment in trunk control and balance contribute to the challenge faced in ambulation for this patient? And how can therapeutic intervention address this issue? Dr. Sakina.
The question. So, what ways do impairment in trunk control and balance contribute? Sorry. So the question is, in what ways do impairment in trunk control and balance contribute to the challenge faced in ambulation for this patient? So if we can see, from the head to toe of the patient or the postural examination in this patient, because of there are some spasticity on the gastrosoleus and also adductor region and also hip discrepancy in this patient. It make the trunk have to compensate the position of the lower extremity area. So if we can see from the, sorry, I would like to share screen again for the postural examination. Postural, sorry. For the postural examination, we can see at the for the postural examination, we can see that the patient have a plantar flexion in the ankle. Then the adductor is very closing between the left and the right side, and also the hip have a discrepancy. And if we can see the gluteal area in this patient, if very posteriorly from the knee and the ankle region, so we can know that the center of gravity in this patient is posteriorly from the base of support in this patient. And that's why there are some imbalance in this patient. And after that, if we can see the hip also with discrepancies, then the posture compensated into the left side, and the head also compensate to the right side. Then and it is the challenge for the ambulation actually, because we have to make him able to do walking independently with this current condition. So we have to think that how we can make a bigger base of support for this patient, so she can the center of gravity in this patient can be in the middle of the base of support. So that's why I give him the posterior walker. So because to make the bigger of the base of support. Thank you.
Yeah, and you
Professor,
can,
you want to add something?
yeah, you can add the grapho. I think then she gets full foot contact, and you force her to extend in knee and hip, and that makes her more stable.
Okay.
Professor, there is one last question from Regina. Professor, would you mind to explain in how do GRF adaptation with long-term AFO use correlate with the improvement of energy expenditure and walking endurance in children with plastic CP? That's from Regina, Professor.
Yes, well, dear Regina, we can repeat the exercise that you stand and then you flex your knee in standing and feel what's happening and well, how heavy it is to stand with flexed knees. Yeah, for actually that's the whole thing. What's happening, and that's why when they become more heavy, so in puberty, that they get more and more problems with walking. So yes, keeping the hip and knee extension in mid-stand, that reduce the energy consumption in walking. Huh? If you don't believe it, stand with flexed knee and feel what's happening. Yeah, and walk with flexed knee and look how far you can walk. As simple as it.
Yeah, I will ask Regina to walk in that way.
Yeah. And I suggest only 1 hour.
1 hour, Regina.
Wow, that's a lot. That's an exercising, Professor.
Yeah, 1 hour, and we will send you the video, Professor.
Yeah, and remember, then you need strong quadriceps to walk on that way. It's so mistake that people think that you walk in flex knee because of weak quadriceps. You need strong quadriceps, otherwise you cannot walk on this way. Yeah. Okay,
Thank you,
but
Professor.
Thank you, Professor.
okay, never forget.
Thank you,
Okay,
Professor.
Any other question from the participants? If not, Professor, you want to add from also any other suggestion for this patient, Professor?
No, I said before, I think the grapho and training the hip extension abduction in high knee position, and you can, when she's able to rise from the floor to high knee position easily, then you can give load according to the strength training principles. You can give her a backpack and then 1 stone, 2 stones, 3 stones to make her stronger and stronger. I think that's very important. And I like to thank Dr. Sakina for the nice presentation. It was really good to see how you examined the child. It was very good. Thank you very much.
Thank you
Thank
so
you,
much,
Professor.
Professor.
And also Lydia with
thank
the proposals about the walking aids and so. It was very nice. Yeah.
Thank you.
And I think keep in mind that in the local situation, you have to try what's doing the best. Yeah?
Yeah.
Okay.
Thank you. It was a roadmap. It's not all at the same time. What I'm presenting was a
The
roadmap.
sequence. Yeah, I understand.
Yeah, thank you.
But it's
The first one.
Okay.
Okay.
Yeah. Step by step. Thank
step
you,
by step.
Professor. Thank you, Lydia. I think this end of the discussion session. I thank you all for the speakers, Prof. Jules, Lydia, Dr. Sakina, also Dr. Irma, and all of the participation. We sure that the knowledge for all us will be useful in daily practice. Now back to the MC, Dr. Jaka.
Thank you so much, Professor Jules, Dr. Sakina, Mrs. Lydia, for the invaluable insight you have shared with us. We deeply appreciate the time and effort you have taken to enrich our understanding through your expertise. Before we move into the next agenda, let us invite to all of the speakers to take pictures. Okay, please welcome to Dr. Marietta, Prof. Jules, and Mrs. Lydia. Let us take pictures. Okay. So, do you wanna, what pose do you want, Dr. Marietta?
What pose?
Okay, smiling pose, right? Big smiling pose. Okay, in the count of three, in 1, 2, 3. That's perfect. And another pose like maybe the favorite, Dr. Regina's favorite, Sarangi pose, right?
This is Dr. Regina favorite.
Okay, in a count in three, in 1, 2, 3. Yeah, so gorgeous, right? Okay, wonderful. Thank you, doctors. So we deeply appreciate the time and effort you have taken to enrich our understanding through your expertise. We would like to formally express our gratitude to presenting you with a certificate as speakers. I would like to invite Dr. Marietta to give the certificates to our speakers.
The screen
The
are yours,
screen
Dr.
are yours,
Marietta.
Dr. Marietta.
Certificate itu
Certificate is
to Professor Jules.
Professor Jules.
Professor,
Professor,
thank you for
Okay.
all
thank you
your
for
time
all
and
your
effort
time
teaching
and
us,
effort
Professor.
teaching us, Professor.
And I
And
hope
I
we
hope
will
we will
able
able
to see you
see
next
you
year
next year
in
in
Bandung,
Bandung.
Professor.
Yeah. I hope also I'm already busy with planning. Okay. Thank you.
Thank you, Professor. And next, Miss Lydia. Lydianya mana?
So we need to take a picture, right?
Oh, take a
With the
picture first
certificate.
with Professor.
Thank you.
Yeah.
Mana setting? Thank you, Lydia, for all the suggestion and the roadmap.
Thank you for the chance.
Okay.
Mana Lydianya?
Thank
Lydianya
you
mana?
for the chance to present in front of you. I feel honored
Okay.
to be able to be present and share to all of you. Thank you so much for the chance.
So we take a pictures with Dr. Marietta and Mrs. Lydia and the
and the
certificates,
certificates,
right?
right?
Okay.
Okay.
With
Smile
big smile
pose.
pose. In
Count of
count of
three.
three.
In
In 1,
3.
2, 3. Right.
Right.
With another pose, maybe. Or what pose do you like, Dr. Marietta? Beauty pose, maybe.
Right.
Okay.
In
In
count
count
of
of
3.
3. In 1, 2, 3. Yeah, that's very beautiful. Okay.
Okay. Next, I would like to take a picture with Prof. Jules. So before we
not
take
take
a
a picture with
picture with
certificate
certificate
yet.
yet.
Oh
Oh
yeah.
yeah,
And with Dr. Sakina.
sorry. Yeah, we haven't take a picture with you, Professor. You, me, and the certificate. We need proof to the faculty, Professor. So sorry.
So sorry.
Okay.
Mana? Certificate? Sertifikatnya?
Okay. Are you ready?
Yes.
Yeah, in the count of three, in 1, 2, 3.
Okay.
Professor, can you give your thumbs up? Right.
Okay. Thank you.
Okay, indicate another voice with thumbs up. Okay, thank you very much, Professor, for the thank you, Dr. Marita.
You want to add something?
And we would like to send our gratitude to Dr.
Oh,
Marita.
yeah.
Yeah.
Now we would like to
And
send
now
our
we would like to
gratitude
send
to Dr.
our gratitude to Dr.
Marita
Marita by present you a certificate as a moderator today. I would like to invite Dr. Regina as the chief committee to give certificate to Dr. Marita.
Please be
Please
welcome
be
to
welcome
Dr.
to Dr.
Regina
Regina and Dr.
Marietta.
Marietta.
She is the busiest person for this today lecture, Professor.
Thank you, Dr. Marietta, for being a wonderful moderator for today's event.
You're welcome, Regina.
Okay, let's take a picture, doctors.
Count of three. In one,
In
two,
1,
three.
2, 3. Now let's
try
try
the
a
free
free
pose,
pose,
maybe.
right? And count of 3 in
In
1, 2,
two,
3. Okay, thank you
Thank you
so
so
much,
much,
doctors.
doctors.
Sorry, Dr. Jaka. I have something to say to Professor Jules.
Okay.
So, Professor Jules, are you here with us? Are you still here? Professor Jules, we would like to say hello to all.
Hello.
Okay. Hello. Bye-bye.
Wait a minute, okay? Wait a minute, wait a minute. Wait a minute, wait a minute. Sebentar.
Wait.
Wait. Kok jadi nggak bisa sebentar ya?
One moment,
Wait a
Professor.
minute.
Sorry, Professor.
Sorry, Professor. Here we are from Indonesia with love. Thank you,
Okay.
Professor.
Okay. You're welcome. I hope to meet you next year. And good luck in your patient care. Huh?
Yes. Hope to see you next year, Professor.
Okay. Okay.
Thank you so very much.
Thank you,
Okay.
Professor.
Okay. Bye-bye. Okay.
Okay,
ladies and
ladies and
gentlemen,
gentlemen,
we
we
have
have now
reached the
reached the
conclusion of
conclusion of
today's
today's
session.
sessions.
On
On
behalf
behalf
of
of the organizing team, I would like to
express our
express our
sincere
sincere
gratitude for
gratitude
your
for your
active and
active and
engaging
engaging
participation
participation
during this
during this
webinar.
webinar.
Your
Your
valuable
valuable
contribution and
contribution and
enthusiasm have
enthusiasm have
greatly
greatly
enriched our
enriched our
discussions
discussions
and
and
made
made
this
this
event a
event a
success.
success.
Before we end
Before
this
we end this
webinar, let
webinar, let
us take
us
quick
take
pictures
pictures
to all
to all
participants.
participants.
Please
Please
open the
open the
camera.
camera. Okay.
Hayo.
Open the camera. Okay.
Please be
Please be
ready in a count of three.
of three.
In one,
1,
two,
2,
three.
3.
Okay, that's
Okay,
perfect.
that's perfect.
With another
With another
pose,
pose,
right? Yeah, Sarangi.
Sarangi pose. Our sarangi to Prof. Jules, right? In a count of 3, in 1, 2, 3. Yeah, that's so gorgeous. Okay, thank you very much. See you on the next time.
Wassalamualaikum
Warahmatullahi
Thank you,
Wabarakatuh.
Prof.
Have a nice day.
Thank you, Professor.
Yeah.
Thank you, Professor.
Thank you. See you next year.
Thank you, Professor.
See you in Bandung,
Thank you, Dr.
Professor. Thank you.
Thank you, Bu Lydia. Thank you, Dr. Marieta.
Thank you.
Jam 6 pas.
Terima kasih Bu Lydia udah hadir.